respiratory disorders. I am not going to talk specifically about congestive heart failure, but about other respiratory disorders, and we'll throw in a couple non-respiratory things just of current interest. Now I got them. There we go. All right. Okay. Remember, basic principles. Respiratory patient, obviously your ABs are the first important thing. Maintain the airway, protect the cervical spine if trauma is suspected. Any patient with respiratory distress should receive oxygen. And any patient suspected of being hypoxic should receive oxygen. And our definition for this county is an SpO2 of 94 or less gets oxygen. Even if they're a cardiac patient, if they're not short of breath and they have an oxygen saturation of 98, they don't need oxygen on room air. So, airway obstruction, upper airway obstruction, common things, tongue, foreign matter, traumas, burns, allergic reactions, and infections. Obviously, your job is to differentiate the cause and then to work with the obstruction itself. Partial obstruction, 100% O2, sit the patient up, have them cough. If the obstruction is not cleared or if it's a suspicion of aspiration, then transport the patient. Complete obstruction, follow American Heart Association instructions, which are what? Yell, help, help. What do you do for complete obstruction? Patient can't breathe. Basically, Heimlich's and then chest thrusts if they're unconscious. And then, if they're unconscious, laryngoscopy, attempt to remove the foreign body with McGill forceps. Obviously, there are some obstructions. Several of our favorite ones. The hot dog, the entire hot dog down the airway. That one's a relatively easy one to remove. Peanut butter. That's our favorite and our worst because it obstructs all the way down, often past the cords. If the obstruction is not able to be removed and you're unable to ventilate, consider crike, consider needle jet insufflation. That's why we have you go through the difficult and advanced airway session at least. We're going to try to do that every year because the more you can practice it, the better the outcome's going to be. And then transport to the closest hospital. Okay. Specific respiratory diseases and syndromes. Adult or acute. Some people call it acute respiratory distress syndrome. It's actually adult respiratory distress syndrome. Basically, it's pulmonary edema, but it's pulmonary edema that's non-cardiogenic in origin, meaning that it's not heart failure that's causing the pulmonary edema. It's increased vascular permeability for whatever reason, decreased fluid removal for whatever reason, and then impaired CO2 excretion, partly because of the edema, and the basic problem is interstitial fluid. There's increase in interstitial fluid because of sepsis, pneumonia itself, pulmonary injury, burns and inhalation, oxygen toxicity, which is why we don't like to give people really high doses of oxygen. High altitude sickness, not cardiogenic, but they develop pulmonary edema on the basis of increased interstitial fluid. Hypothermia, near drowning syndrome. This is why we tell you that if you have a patient who's been near drowned, who is now resuscitated and is now talking with you and seemingly okay, you still transport them. That patient has about a 30% chance of developing non-cardiogenic pulmonary edema, acute respiratory distress within an hour. Look at the, there's another one up here, drugs. Drugs. Most commonly, things like narcotic overdose treated with Narcan. It's a combination of the two things that predisposes to non-cardiogenic pulmonary edema. So those kind of cases, they get that's why we don't have you leave them at home. Pulmonary emboli, head injury itself can induce interstitial fluid shifts, which give ARDS. Pancreatitis, cardiac arrest. Many people they develop after cardiac arrest. You've got a good ROSC, and then they go into what appears to be congestive heart failure. Basically, it's increasing interstitial fluid, and so you get got a duck in my pocket. Yeah. Sorry about that. Okay, now the duck is turned off. Interstitial fluid, interstitial space widens, and it just decreases, among other things, it decreases the ability of oxygen and CO2 to be transported across that space and across the membrane and into the intercapillary space or out of the intercapillary space. Very high mortality. It's associated with multiple organ failure. What we have to do is deal with the symptoms, assuming the underlying cause, and the symptoms are of course shortness of breath, confusion, agitation, signs of hypoxia, abnormal breath sounds, comatose or near comatose state, which is a sign of increasing CO2. They will have crackles or rales in their lungs, just like you do in heart failure, just like you do in pneumonia, just like you do in interstitial lung disease. We manage the underlying situation, provide supplemental oxygen, support respiratory effort. Positive pressure ventilation is the treatment. So CPAP if they can tolerate it. If they need to be intubated, it's ideal to have them have a PEEP valve in between. We have 5 to 10 milliliters of PEEP. Monitor cardiac rhythm, vital signs. They almost always have some cardiac dysrhythm associated with it. Medications can be considered. Corticosteroids seem to help at times, but you don't carry enough to make any difference. So that's not really a pre-hospital treatment. Obstructive lung disease, another different flavor. Emphysema, chronic bronchitis, or asthma. Now, there's a clear genetic disposition. Some people, although they smoke all their entire life, do not develop emphysema or chronic bronchitis. Asthma has a clear genetic predisposition. It runs in families. Smoking is implicated in all of the above, emphysema, bronchitis, and asthma. And whether it's second-hand smoke or first-hand smoke or even third-hand smoke, I suspect. And then there's occupational exposure for obstructive lung disease, but very few of us are coal miners or Navajo digging for uranium, so we don't have as much risk on that. Asbestos exposure. This is why they go through all that stuff to redo an old house or business and take out the asbestos. The pathophysiology is basically an exposure to a noxious substance, whether it's asbestos, smoke byproducts, and you get destruction of the wall of the alveoli, increased residual volume. This is with emphysema. And then they develop cor pulmonale. You know what cor pulmonale is? The cor pulmonale is right heart failure. Right heart fails because of chronic pulmonary hypertension caused by increased resistance of flow through damaged, non-compliant lung tissue. You get back pressure on the pulmonary veins, and you end up with the right heart has to accommodate for that and develops right heart hypertrophy and then right heart failure. Signs of right heart failure include such things as jugular venous distension, liver congestion, which you can determine by pressing on the liver, and you see the jugular veins distend when you press on it. That's called the hepatojugular reflux. That means you've got increased right heart pressure and increased venous capacity at that point. They also often develop polycythemia because their lungs are not very efficient. Your body decides to compensate in several ways. It can make a barrel chest, which increases the surface area available for alveolar oxygenation and CO2 removal. But one of the other ways is to increase the amount of hemoglobin carrying blood. So they develop more blood. So instead of having a hematocrit of 40 to 45 for an adult male, they have a hematocrit of 50 to 55. And at 55, your blood is pretty thick, pretty sluggish, has a tendency to clot, has a tendency, curiously, for increased risk of infection, and tendency to develop dysrhythms and cardiac failure. So, although it's a compensatory mechanism, it's one of those ones that has some downsides. So, basically, in obstructive pulmonary with emphysema, you have destruction of normal alveoli, and you get big, ugly, they colored it black so you know he's a smoker. You get destruction of the alveoli. And what you do is just basically decrease the surface area. You know, a lot of little alveoli have a lot more surface area than a bunch of big air sacs. Often a barrel chest. There's a prolonged expiration phase. One of the problems with emphysema and ultimately with asthma when it's fully developed is there's difficulty getting air out as well as getting air in, but there's more difficulty getting air out because the bronchioles have a tendency to collapse as they try to force air out. So there's a prolonged expiration phase, and therefore that decreases the rest phase of respiration. So they'll be breathing more rapidly, but it's prolonged expiratory phase. Often thin, maybe with a pink skin. Of course, this doesn't make any sense then to show a black person on the thing. I mentioned that to my choreographer here. But the pink skin in light-skinned persons is because of if they have polycythemia. Hypertrophy of accessory muscles because because they're primarily diaphragmatic breathers until they get into trouble, and then the accessory muscles, because of the barrel-shaped chest, you've already expended you've ruined the action of the intercostal muscles there because your chest is continually expanded, basically. So you have to pull the accessory muscles in, such as the sternocleidomastoid. So they'll often be breathing using you can see their neck muscles working when they're trying to breathe. They also have, of course, no exercise tolerance. You can see that most of them who are fully developed emphysema will have supplemental oxygen often. Now, chronic bronchitis is a little bit different flavor. That basically is an increase in the mucus-secreting cells in the respiratory tree, and so they have increased mucus, and increased mucus means they can have more substrate for bacteria and viruses, for that matter, to live in and to create a low-grade infection, a bronchitis. The alveoli themselves are relatively unaffected, except they're often full of this mucousy pus kind of stuff, so they will be coughing up a purulent sputum. There's decreased alveolar ventilation, however, because the mucus plugs up the bronchioles and the even smaller bronchioles, so that you don't get good alveolar ventilation. You don't get a breath down to the level of the alveoli. They have to have a history of frequent infections to be called chronic bronchitis, and I think the definition, as I recall, is at least 6 months out of the year they must have active bronchial infection to be called chronic bronchitis. Obviously, they have a productive cough. That's one of the heralds. The cough is often purulent, colored sputum, greeny, yellow, whatever, sometimes blood tinged if they're really coughing away. Now, converse to the true emphysema patient, these are often overweight. These are sort of the blue bloaters, not the pink puffers. Rhonchi are present. What are rhonchi? Rhonchi are giant rowels. They're noisy, wet sounds from the bronchioles that you can hear sometimes without a stethoscope. Mostly, you can hear them centrally mostly, whereas rowels you hear best at the periphery of the lung, the crackles. These are rattly, noisy things. Jugular vein distension, secondary to cor pulmonale, pedal edema, and hepatic congestion, all signs of right heart failure. Now, often, right heart failure occurs chronically because of left heart failure, but in the case of an emphysema patient, they may have perfectly normal left heart. Most people who have congestive heart failure, you say, well, you know, they got congestive heart failure, and I went out and they've got pedal edema. I can push on their pretibial. I can leave an imprint of my thumb, and it stayed for half an hour. You know, they've got chronic pedal edema. They've got a history of chronic congestive failure. This is left heart failure, but it's reflective because the right heart has to fail if the left heart is failing. And that's treated differently. We treat that primarily by fluid restriction, giving them diuretics, giving them medication that tune up the left heart to make it function better. Now, our orders. Let the patient achieve, for COPD, patient gets position of comfort. Couple liters of nasal oxygen unless they're cyanotic. If you have a suspected MI in this kind of a patient, because they're going to have a low O2, that's going to be under 94, or severe respiratory distress, and they have a high flow by mask. Be prepared to assist respiration. Consider CPAP. In that case, any patient who is short of breath for whatever cause, you may consider CPAP on that patient if they tolerate it. What are the contraindications to CPAP for a paramedic? An unconscious patient. They can't cooperate. They can't do it, can they? A patient who's vomiting into the mask, not a good idea. A patient who can't tolerate the mask, not a good. A patient who's not doing better with it. How do you know they're not doing better? Well, their O2 sat is falling, their CO2 is going up, and they're becoming hypotensive. One of the problems with CPAP or anything with positive pressure is that you can increase intrathoracic pressure. If you increase intrathoracic pressure, you will sometimes drop their blood pressure. Now, if they start out hypotensive and you're a paramedic, I would still let you, if they're hypotensive, 90 or so, and they're still alert, able to tolerate it, you put it on and see if they get better. If they don't get better, take it off and go to something else. That's what you're going to do anyway. Remember, you can give the other treatments with the CPAP going on. We have the adapter kits. You just go ahead and you can do the MedNeb, which comes up down here. Remember, if you intubate the patient, it's okay with RSI to use lidocaine on a COPD or any reactive airway type patient, because that decreases that cough reflex, among other things. So it may make your intubation and care better. IV TKO. Watch for dysrhythms. Dysrhythms are common in COPD, everything from PACs to supraventricular tachycardia to runs of what appear to be VTAC to lots of PVCs. Also, because of the medications, because of the multifocal atrial tachycardia is common in COPD patients in trouble. So, then albuterol, 2.5 milligrams with atrovent, 2.5 milligrams or mils, and you can repeat that pretty constantly. We say times 2. That's an average time around here to get to the hospital with the patient. Solumedrol, 125 milligrams, single dose. Whether it takes effect at that moment or not is a moot point, but with asthma and with COPD exacerbation, they get better with early corticosteroid treatment. Capnography, I want to see capnography whenever possible. Side draft, if you've got the patient intubated, of course you have to have capnography, but we can help to ascertain the ventilatory status. Remember, the normal CO2 range is 35 to 45, but with the COPD patient, if they're a chronic CO2 retainer, they may be higher. Don't be upset. And you can always ask them if they're awake. You can ask them if they're a CO2 retainer. Nowadays, good doctors tell their patients, good respiratory docs tell their patients if they're a CO2 retainer, because it's a good thing to know. Because they may have a CO2 of 52, and you've done your best, and they're much more relaxed. They're breathing fine. They're feeling much better, and you say, CO2 is still pegged at 52. That may be their norm. Asthma. Asthma is a chronic inflammatory disorder which has both a environmental and a genetic and an allergic character to it. What it results in, for whatever cause it, is widespread but variable airflow obstruction, which an airflow obstruction gives you wheezes. So the hallmark of asthma has always been wheezes, and expiratory wheezes come before inspiratory wheezes, generally speaking. But they also go away when airflow decreases significantly. So the absence of wheezes doesn't mean a good deal for some asthmatics. You have to look at the patient. If they're not wheezing but they're semi-obtunded, that's and breathing at 45 times a minute, that is not a good sign. The airway becomes hyper-responsive to stimuli. And the trigger stimuli varies, but no matter what the trigger stimuli, the basic thing is a sudden release of histamine, which causes bronchoconstriction, bronchial edema, and after a period of hours, immune system cells invade the bronchial mucosa and cause additional edema by by giving off other substances, slow-reacting substance of anaphylaxis, the bradykinins, etc. All these things are released from the immune system cells, primarily mast cells, that cause the additional edema. So a normal bronchiole looks nice and free and clear, and the asthmatic bronchiole has just huge amounts of edema, mucosal edema. The mucosa now is swollen, edematous, very narrow airway. There's usually a little mucus as well, which further obstructs, because asthmatics often make what are called mucus plugs. The mucus sort of gels up, and they'll end up coughing out these ropey little bits of mucus. So, with an asthmatic patient, just like with the COPD emphysema patient, identify the immediate threats. So, one word to 2 word dyspnea, decreased breath tones, absence of wheezes in a patient who's got low oxygen saturation, tachycardia. In your history, besides the normal history you're going to get as much as you can get from the patient, get history of asthma-related hospitalization. If they've been hospitalized in the last 24 months for asthma, that means they're significantly asthmatic. They get max treatment. If they've had a history of failure or ventilatory use in the past, they are also at high risk then for respiratory failure. Okay. If they beg you to intubate them, you know they've been there before and they want you to breathe for them. Now, their presenting signs may include dyspnea, wheezing, and cough. Remember, wheezing is not there at the, in extremis. Speech may be limited to 1 to 2 consecutive words. Look for hyperinflation of the chest and accessory muscle use. Now, in between the attacks, they don't have the hyperinflation of the chest, but asthmatics frequently have hyperinflation, and so they're really at risk when you are doing positive pressure ventilation. They're really at risk to tip over and get into the hyperinflated chest, increased intrathoracic pressure, and ultimately shock from hypotension from the increased intrathoracic pressure. People have done all sorts of things to try to improve the, first of all, you have to if you do intubate the patient, you slow down your ventilatory rate, slow down your volume. You don't want to hyperinflate that chest, because you want to, remember, the problem just with the asthmatic, just like the severe emphysema patient who's in trouble, is the expiratory phase is very prolonged. So you slow down your ventilatory rate, and some people actually do gentle thoracic compression to try to increase expiration when the patient's intubated. It's pretty hard to do that while they're awake and participating with it. Auscultate breath sounds. If the patient's awake and has their own peak flow meter at home, they may have used it already. Ask them to use it to see what basically you'll probably find out that they have extremely low, like peak flow in the 600 range, which is very, very low. Capnography will reveal the shark fin kind of prolonged. This is the expiratory phase, prolonged expiratory phase. So decrease inspiratory phase and a prolonged expiratory phase, giving you the shark fin looking appearance. Treatment goal is to correct hypoxia, reverse the bronchospasm, reduce the inflammation, at the same time maintaining the airway. They will need high flow, high concentration of oxygen or assisted ventilations with a rate not to exceed 10 per minute if they're intubated. If they're awake, position of comfort, high flow tube by mask. If you're a known asthmatic having a recurrent attack, or an unknown asthmatic to you having an attack, albuterol and Atrovent by MedNeb. May repeat. Child's dose is that's an error there. Child's dose is incorrect on the slide here. It says 5 to 10 milligrams per 3 cc. Well, we just increased us there. So I think we'd go at about 0.5 to 1 milligram per 3 cc's if it's a little kid. Kids are very tolerant to this medication, so you can use as much as you want. Solumedrol, 125 milligram IV. Child's dose is 2 milligrams per kilo. If they continue to have difficulty and are not responding, magnesium, 2 grams in 50 to 100 cc's over a 4 to 5 minute period. Child's dose is 25 to 50 milligrams per kilo. CPAP, if tolerated. Of course, that would go way up at top. You can do that at the beginning. Intubate as needed using lidocaine is okay during that RSI sequence, just like with the COPD. Now, remember also, I forgot to put it in this, if you're using RSI sequence, we prefer if you're using RSI, for the sedative, we would prefer in the asthmatic to use ketamine as your sedative agent. Child in status, unable to ventilate or administer MedNeb epi infusion starting at about 0.1 micrograms per kilo per minute, or which is 0.1 cc's per kilo per minute. Or you can also give it IM if you couldn't get an IV. And hopefully by this time you've got an IV, because it's pretty hard to do RSI without it too. So epi infusion. The question is coming up, and let's say you have, well, we'll go to the next one, which is status, which is a severe prolonged attack that can't be broken by bronchodilators. You continue your MedNebs. In an adult, would I tolerate you giving an epi infusion? I would think yes. You'd have to call me and tell me about it after the fact. But I don't see any reason to let anybody die of asthma. We have good control over epi infusions with starting at about 1 mic per kilo, 1 mic for the adult, making up your standard dose just like you would for a severe allergic reaction. Rather than let somebody die because of status asthma, I would certainly go ahead and try the epi. You'd have to watch carefully for dysrhythms and things, but I don't think that would be a real issue to me. You've already got a tachycardia. Asthma in children we manage just like they were little adults, just adjusting the medication. They're all in your correct dosing. All right, upper respiratory infections. Frequent patient complaint, common pediatric complaint. Rarely are upper respiratory infections per se life-threatening, but perhaps they become life-threatening with other comorbid factors. Frequently caused by viral and bacterial infections. Multiple parts of the airway are affected, typically resolve after several days of symptoms. So the infection of the upper respiratory infection of the nose is rhinitis. The symptoms are runny nose, snotty nose. Pharyngitis or upper respiratory infection of the pharynx, Sore throat, pain on swallowing, could be an erythematous pharynx, tonsillar enlargement, pus on the tonsils. Some of these could be bacterial, could be strep. If it turns out to be strep pharyngitis, then it needs to be treated with penicillin or an alternative if you're allergic to penicillin. That's not to treat the throat. That's to treat the side effects of having an untreated beta strep infection, which at some times will cause a patient to develop essentially an autoimmune syndrome, which affects either the kidney, acute glomerulonephritis, or affects the heart, rheumatic heart disease. And those can have long-lasting effects. So that's what we treat sore throat, tonsillitis, strep for. Middle ear infection, otitis media, ear pain, decreased hearing. Often they'll have a lymph node enlargement behind the ear. We'll look in the ear and see a red eardrum. We don't treat a lot of kids anymore with antibiotics for otitis media, only if it's severe pain and severe fever. Laryngitis, sore throat, hoarseness, pain on speaking. Epiglottitis, an extension of that. Sore throat, drooling because they can't swallow, it hurts so much. Ill appearing, they're usually extremely febrile. We don't see epiglottitis in children anymore to speak of, because even though it'll probably come back because parents are not getting their kids immunized for all sorts of ill-conceived reasons. It's a Darwinian expression of survivability, I think. But we now treat for. They developed a immunization against Haemophilus influenza, which was the most common cause of otitis media in children, and also the most common cause of meningitis in children, because the infection would spread from the middle ear to the meninges, and cause meningitis. So they developed the H influenza immunization, and now we don't have that kind of meningitis to worry about, by and large. And it just so happens that Haemophilus influenza was the bacteria that caused epiglottitis in children as well. So they're all going away. And so we don't see kids anymore. Is anybody, I don't think anybody here, I cannot recall reading a chart that turned out to be childhood epiglottitis in the last 10 years, roughly. What we are now seeing is older kids and adults who have epiglottitis, and it's mostly from a staph bacteria. So they were sitting up, having the sore throat, the drooling, that kind of stuff, and ill appearing, but they're not as difficult to manage as children with epiglottitis, because they have a much larger airway to start with. So we don't see a lot of epiglottitis anymore. Sinusitis, headache, congestion, tenderness over the sinus. So, acute respiratory infection, look for older underlying illnesses, evaluate for airway obstruction, not just for epiglottitis. Maintain the airway, support breathing, treat signs and symptoms. If the patient has hoarseness and stridor, we often treat hoarseness and stridor with racemic epinephrine. If you think the child has the croup, we use croup, and the infection in croup is just subglottic, is just below the just below the level of the cords. So that often responds to a little racemic epinephrine. And remember, the rule is you make sure that everybody knows you gave this patient who's now breathing well and not crouping, you gave them a little dose of racemic epinephrine because we're duty bound to watch them a little longer than we might otherwise. So, all right. Now we're getting down from the upper airway into the lower airway. Pneumonia. Bacterial or viral infections. Now, we have to make a distinction nowadays between hospital-acquired, which are usually nastier bugs, than community-acquired infections. Although in the community-acquired infection, either going to be usually viral or strep pneumonia. Now, strep pneumonia has gotten pretty vicious at points, and we'll have a case in point later on today. And the infection can spread from one localized area in the lungs, can spread throughout the lung. Alveoli collapses, and then when the alveoli collapse, you get a ventilation perfusion disorder, so that it affects your respiratory status, your ventilatory status, much more than you would think just having an area of the lung collapsed. You can get along. People get along with missing half a lung. We used to operate on lungs all the time for tuberculosis. They would get along fine with that. No, so just missing a lung doesn't necessarily change your ventilation perfusion. It's a lot worse if you have an area of collapsed ventilation, a collapsed alveoli, because you have blood flow through that, but you don't have air flow through it, and that affects your. And just like with pulmonary emboli, they do the same thing. Aspiration pneumonia is very common. We see a lot of aspiration pneumonia around here, particularly places that have huge numbers of, a large number of elderly persons, particularly in care facilities. I see that in District 6, they're building a new care facility that has something like 3,000 patient potential. That'll be nice. So, with pneumonia, focus history, physical examination. Ask for recent fever, chills. The characteristic of bacterial pneumonia, particularly strep pneumonia, is shaking chills, or what's called rigor, shaking chills. Weakness, malaise. Malaise means they don't feel good. Deep productive cough, often with associated pleural pain, so you get pain in the chest. Most of the time they'll be tachypnic. Most of the time they'll be tachycardic. Crackles or rowels are characteristic of pneumonia. They're also characteristic of congestive heart failure. Sometimes it's hard to differentiate the two. Sometimes when an old person is septic, they'll look at them, they'll have pedal edema. They won't have a fever because they would have had a fever, but now they're septic and they don't have a fever. Matter of fact, it's usually subnormal, which is just as good as a fever. And you hear crackles, and you don't know if it's congestive failure or if it's pneumonia. Well, if it's pneumonia, we probably don't want you to dehydrate them. That's one of the reasons we got away from a lot of Lasix in congestive heart failure. Treat them for their respiratory problem, their hypoxia, their, if they can tolerate, if they're awake or with the program enough to tolerate a CPAP, fine, try that. Respiratory failure. And you happily will treat congestive failure if they have it at the same time. You'll probably have to restrict their fluids a little bit, worrying that they might have congestive failure. Support breathing. high flow, high concentrated oxygen. Think of CPAP again. Monitor vital signs, IV access, but no fluid overload. Now, we're going to give them antibiotics if they're a reactive airway. If you have wheezes in there, treat it with wheeze medicine. Oh, now into some fun things. Severe acute respiratory syndrome, or SARS. This is from a coronavirus, the SARS-CoV. Viral respiratory illness first appeared in southern China in 2002 and became a global threat in 2003. We became very excited about it when a bunch of Canadian physicians and healthcare workers taking care of some of these people died because they got it. Starts as an upper respiratory infection. You think you got a cold. Now the virus itself, which is spread primarily by respiratory droplets, the virus can survive for several days in the dried out droplet form. So they'll get on surfaces, they'll get on stuff, and so you get it on your hands and you ultimately get it into your mouth or up your nose or wherever you're going to put your hand. It requires ordinarily close person-to-person contact, but it's respiratory droplets. Incubation period is 2 to 7 days, ordinarily. It's contagious. The patient is contagious as long as they're symptomatic. Now, SARS has, I think, an adjusted mortality rate of about 30 to 35%. So that's pretty big. So, when do you worry about it? You worry about it when we say there's a SARS outbreak identified. So if you're the first person or the fifth person, you're probably screwed. You know, because we have to identify, you have to identify there's an outbreak. All patients with SARS-like symptoms then, once you identify the outbreak, you say, okay, this person is high risk if they have sore throat, rhinorrhea, chills, rigors, myalgia, headache, diarrhea, cough, productive sputum, respiratory distress. In other words, they seem to have a severe cold or flu, and you think there's a SARS epidemic or outbreak going on. Then those patients need to be managed. They get a high flow, high concentrated oxygen, IV fluids, cardiac rhythm, pulse ox, ventilatory assistance as needed. They need to be intubated for severe respiratory distress or failure, nebulized bronchodilated for bronchospasm, notify the receiving hospital your SARS, and you take all the protective measures you can. You're in a full military dress out period at that point. Mask, gown, gloves, eye protection, and you manage everything as if all those droplets, every droplet that guy spews out, you're going to get if you don't have these protective things on. You say, well, we haven't had a SARS outbreak for a while. No, we haven't, but we get other ones that are just fun. MERS, Middle East Respiratory Syndrome. This is caused by a coronavirus again, and it's called the MERS-CoV. 2012, started in Saudi Arabia. Most likely came from an animal source. The virus is endemic in camels and bats. Interesting combination. It has also a 30% mortality rate, but the majority of the people who died had comorbidities such as heart disease, such as other underlying respiratory, emphysema, etc. Or extremes of age, old and young. Transmission, once again, is close contact and airborne droplets. All reported cases have been linked to to countries in or near the Arabian Peninsula. We've had 2 cases in 2012 in the United States. Both have been in Saudi Arabia recently, so that's where they picked it up. So you're at risk for MERS. MERS pops up. Recent travel to the Arabian Peninsula or close contact with an ill traveler who's been in the Arabian Peninsula, who has had contact with a confirmed MERS case. Your risk is almost 100% if you're not using appropriate PPE. And if you have a lot of contact with camels, you're in trouble. WHO says avoid contact with camels, unless you use proper precautions. Don't drink raw camel milk. Mark says don't drink camel urine either. I'm not sure about that. Or don't eat undercooked camel meat, which is probably going to be a problem for most of us. Symptoms are flu-like, cough, fever, shortness of breath. They may have GI symptoms, and you treat them if they're symptomatic. Once again, you protect yourself by protective things. Now, this is not, strictly speaking, just a respiratory illness, but Ebola is a hot item right now, where, as a matter of fact, there's a couple meetings this week in which we'll be discussing the EMS response to Ebola. Ebola is called Ebola hemorrhagic fever or Ebola virus disease. First outbreak, 1976 in the Congo, near the Ebola River. It isn't going away. The exact origin is unknown, but fruit bats are a natural host. It's contagious to humans, monkeys, all sorts of things. So why, and in many countries that I've been in, people eat fruit bats. Transmission, however, only occurs with contact with blood or body fluids of the infected person. However, that individual is not contagious until the symptoms appear. Right now, it's limited to 4 countries in West Africa, but it's a hot item. As of the 16th of August, almost 1,400 lab-confirmed cases, which means there's probably 1 to 2 times that many that aren't lab-confirmed. Remember, these are West African countries. These are 3rd, almost 4th world in the outback. 1,229 deaths of the 1,383, which puts you as pretty damn close to 85% mortality rate, and in some countries it's 90%. 2 confirmed cases we've had in the United States were healthcare workers traveling from Liberia. They were transported from they knew they were sick, so they were coming in being sick. They had personal protection, and the people transporting them had lots of personal protection. They were transported in full protective outfit from the airport to the hospital. Both went to the same hospital, and they did survive. They were treated with an experimental drug which doesn't seem to be available anymore because they used it all up. Symptoms appear anywhere from 2 to 21 days from exposure, usually 8 to 10 days. Now, I think it helps to, no matter how we work out the information system to EMS. I mean, let's face it, you guys are not at risk except on that very rare case where you might be called to transport a patient from the airport who comes in sick or who becomes sick after arriving back from West Africa. So that person becomes what's called a person under investigation with a fever of 101.5 plus severe headache, muscle pain, vomiting, diarrhea, abdominal pain, and or unexplained hemorrhage, and a history of a travel to West Africa or a place where there's active disease within the last 21 days. So that kind of narrows it down to healthcare workers who are there, kind of narrows it down to State Department kind of folk. That's kind of, and very, not a lot of them are going to be rolling into Portland area, into the Portland airport, except there are a number of people over there now with Mercy Corps and with Northwest medical teams. Although Mercy Corps is making a point to avoid being involved with patients. That's not their primary mission anyway. One of the problems with West Africa is that there's a high number of, or a high percentage of the population is Muslim, and Muslims must go through preparation of the body for burial very quickly, and washing and a wrapping and such, and you can get it by exposure to the body as well. Patient doesn't have to be alive because they will have the body fluids, they will have the droplets on their person, and of course, so that's a worrisome part of the control. Now, so if you have a person under investigation with those symptoms and you're concerned, supportive care to that person, notify the receiving facility of the suspected case, wear full protective outfit. We have they worked out at the airport for the Portland fire that goes to the airport for that potential. There is a full outfit that they put the patient in, including a respirator, a full face respirator kind of mask, full outfit. And they're transported inside almost a hermetically sealed container. Wear your protective gear, take it off in the appropriate manner, and wash your hands when you're done, and then wash your hands again. So just all contact and droplets. These are droplets. You can protect against that. Okay, break time. I have 10 o'clock on that thing. We will take a break for exactly 10 minutes. Dr. Bell wanted me to inform you also of there's an enterovirus that's being reported from by CDC from the Midwest that causes an upper respiratory infection in kids that in many of them have gone on to essentially respiratory failure, and they need to be intubated. Apparently, it's there's the first sort of epidemic nest are reported out of Denver but apparently it's sort of it hasn't been called Midwest anything yet, but it seems to be a potential for a new viral thing that's particularly big with kids. Apparently, they probably have with Denver. It may be related to some altitude kind of issues as well, but. Right. So we haven't seen any spread of that to this area yet, or at least not enough to be reported as epidemic. I was informing Dr. Bell that my brother was complaining that his grandchildren have been visiting him from the Midwest, and now he and his wife have had a respiratory thing for the last 6 weeks. So perhaps he's going to be our index case. So if you run into anybody with a last name Whitwer, put on your outfit. In general. So all right, on to respiratory illnesses. Lung cancer. Well, the primary problem is disruption of diffusion in lung cancer. It may also be alterations in ventilation by obstruction. The majority of lung cancers are carcinogens secondary to cigarette smoking or occupation exposure. However, there's enough small cell lung cancers and other subgroups that are not related to cigarette smoking. People, you can get cancer any place, and so often lung cancer is metastatic to the lung from another source, liver, bone, etc. High mortality, of course, in lung cancers. And the cancerous machine doesn't want to work here. Okay. Oh, yeah. Let's yell at Mark out there in the corner. We're frozen. Now let's see if it works. Okay. Okay. Types of lung cancer: adenocarcinoma, the common thing caused by cigarette smoking. Small cell carcinomas, epidermoid carcinomas, large cell, nevertheless, you end up with a mass in the lung. The lung tissue is being taken over by the tumor. You're not going to get caused for an asymptomatic person, someone who just says, "Oh, I have lung cancer." But you're going to cause because they have symptoms. So, focus history, physical exam. You want to know about cancer-related treatments, hospitalizations, evaluate for respiratory distress. That's the primary reasons they call you for lung cancer is they have respiratory distress, which may or may not be related to the cancer at that moment, and or they're coughing up blood, because everybody gets excited when they cough up blood. So your general treatment is oxygen support, ventilation is needed, provide emotional support. If they happen to have a cardiac arrest and it's you go through your normal you follow your cardiac arrest or your post instructions. If they don't have post instructions, we still do normal resuscitation. Your duty is to treat. You go there, you treat it, but you may, if they're in an asystole, I think I'd stop after the first round or two. Toxic inhalation now gets down to more respiratory, good respiratory, upper respiratory and lower respiratory system. Inhalation of heated air, chemical irritants, and or steam. Airway obstruction occurs due to airway edema and laryngospasm. And laryngospasm can occur due to thermal or chemical burn. Attempt to determine the nature of the substance when you're doing your history. Length of exposure, whether there was loss of consciousness. So, your protocol says protect yourself. Patients should be removed from the area of toxic substance by personnel equipped with proper gear. In other words, the hazmat crew. Initial intervention, drug therapy, early contact with medical control or the Poison Control Center at Marybridge, Oregon Health Sciences. Assist ventilations, 100% O2. Intubate as needed. Intubate early if they have signs of upper respiratory burns, facial burns, smoke, charring around the nose, burned nasal hairs, edema of the upper airway, and or stridor, hoarseness. Intubate early. Another one that might be worthwhile to consider using ketamine. Monitor vital signs. Balanced salt solution is used. Albuterol for wheezing. We treat wheezing with wheeze medicine. Now, specific therapies. We have a few. Chlorine gas uses humidified 100% O2. They're going to have severe, if it's a significant exposure, pulmonary edema, bronchospasm. Treat that per protocol. CPAP or intubation and a PEEP and albuterol. Cyanide inhalation. Well, cyanide, you suspect a closed space fire. They have altered mental status and or seizure, coma, tachypnea, apnea, shock, vomiting. If their symptoms persist despite 100% O2, you might consider, the usual thing is carbon monoxide poisoning, or simple unconscious due to hypoxia. But patients not responding to 100% oxygen and still comatose is probably, you can say, well, it could be cyanide poisoning. Close space fire, plastics, burning of insulation, things like that. If the patient was unconscious and is now awake, struggling, talking to you, it's probably not significant cyanide poisoning, even if there was cyanide. So you don't have to get all excited about it. If you think it's cyanide, nowadays we are treating with sodium thiosulfate, only thing you're carrying, 50 cc's of a 25% solution over a 10-minute period. And there's a child dose involved in that too. We do not carry the cyanokits now. We leave that to the hospital. It's just too damn expensive and not indicated enough. The other thing with the cyanokit is that if you treat with the cyanokit, you can't get a CO2 measurement or a CO measurement after the fact, and you can't even get an accurate SpO2 because it changes the colorimetric of the blood, and you end up, the burn centers get very excited because they can't do a SpO2 on the patient for up to 2 weeks. Which means they have to get an arterial blood gas every time they want to see what the gas is on the patient. So, hydrogen sulfide, if hydrogen sulfide causes respiratory depression, so you assist ventilations. And they also have seizures, so treat seizures per protocol. Carbon monoxide, colorless, odorless gas. it's incomplete combustion of carbon-containing compounds, often in confined spaces, such as a house fire, mines. We don't see a lot of them around here. Autos, people like to sometimes commit suicide by sticking a hose into their, I don't know how they can tolerate the odor, but that's another story. Because it's not the carbon monoxide that stinks, it's the rest of your exhaust. Poorly ventilated homes, so we do see, obviously, when there's problems with furnace systems, when people are burning things inside a house that should have been better ventilated. So there's some hazard, of course, to firefighters and rescue personnel. It works by binding to hemoglobin, so it prevents oxygen from binding. It creates hypoxia at the cellular level. Now, it appears to a standard pulse oximeter to be oxygen bound to hemoglobin, but it's CO bound to hemoglobin. And of course, the patient is then hypoxic. Now, that's why we have the Masimo has the RAD57 and other devices that are CO2. It's a pulse CO2 meter, or CO meter rather. So that way you can actually determine if they have carboxyhemoglobin. We'd like to know the source, the length of exposure. You guys have, there's some very clever little devices out there now that I've seen some, at least back east, some of the units are carrying. It's a CO detector that samples room air, and they cost about $150, and these guys they carry them in, particularly in the wintertime when there's potential. Every time they just have it in their kit, on the outside of the kit. So if they go in a room or a house, and the CO2 or the CO detector goes off, and it's quite accurate, and it might be something to have if you have a risk of that sort of thing, because it's a very inexpensive way to test, and they find a lot of carbon monoxide sourcing that way. Patients will often present with flu-like symptoms: headache, confusion, feeling ill, lack of coordination, and now for the extremes, particularly when you get up over about 25 and the CO, loss of consciousness and seizures. So if you had a number of patients in a house with altered mental status, and if their pets are sick, that might be a possibility to consider CO poisoning. 100% room air. CPAP helps. And in the case of hazmat for firefighters, if someone, as a part of the normal hazmat process, is to test you after a fire for carbon monoxide. We all have a base level of about 0.5 to 1, but if you have an elevated resting level, that means you're either a heavy smoker or you've been exposed in that fire, and we assume that. And it helps to use 100% O2 with a CPAP. That'll clear about 3 times faster than if you just do 100% O2 by mask. Determine the carbon monoxide level with a Masimo RAD57. Determine CO level before you before you use a cyana kit, and an SPCO between 3% and 25% with symptoms, headache, dizziness, nausea, syncope, etc., is treated and transported to the emergency department. An SPCO greater than 25% with symptoms, and in that case, greater than 25%, you're probably looking at seizures, coma. Pregnant women are high risk here. People with heart disease. That patient should be diverted more than likely to a hyperbaric chamber, contact medical control. Symptoms are treated by protocol. All patients would be on a 12 lead to rule out ischemia, chest pain, angina, and MIs are in medium level doses of carbon monoxide poisoning because the patient is hypoxic at the cellular level. Pulmonary embolism. Obstruction of pulmonary arteries, arterioles. Emboli could be air, thrombus, fat, amniotic fluid. The most common thing is of course thrombus from the deep vessels, the large vein, deep vein of the leg, or the veins around in the pelvis. Now you can also get emboli from upper extremity thrombus, but it's less common, and it's also not generally fatal. Risk factors for pulmonary emboli are the risk factors of hypercoagulability, which is recent surgery. So there's increased coagulation from the recent surgery, long bone fractures, which could be thrombose, some fatty structures from the bone marrow, pregnancy, which increases your coagulability and also slows the venous flow out of your lower extremities, especially late-term pregnancy. Postpartum, same differences. Oral contraception use, which increases the risk of clot. Tobacco use, we blame everything on tobacco, but it's true. That's why. So, assessment, focused history, physical examination, risk factors. I'm always amused, and I see it not so much with EMTs as sometimes with physicians who say, after working up a patient for vague and unexplained chest pain with EKGs and the like, and say, oh, by the way, you should probably have that cast on your leg looked at. Risk factors. Somebody who's got a recent fracture and has immobilized extremity. Someone who's been on a long trip, particularly air trip. Someone who's been prolonged in a car, driving a car without getting out, moving around. You go on a long distance air travel now, and they play little things in between the movies, telling you how to get up and walk around and wiggle your legs and do stuff. The French did a study showing that about 13% of persons who got off an intercontinental flight had increased coagulability and some evidence of potential deep vein thrombosis. So you should move around a lot more. So risk factors, sudden onset of severe dyspnea and pain. Pulmonary embolus is one of the great masqueraders. It can present as all sorts of stuff. I've always thought that unexplained tachypnea is something you have to be aware of. If you can't tell a reason for someone to be tachypnic or tachycardic, that's one of the things you have to consider in the differential. Physical exam, You might see some signs of heart failure if you're lucky with JVD and hypotension as a reflection of increased pulmonary hypertension again. A warm, swollen, tender calf or lower extremity. Now, if they're in a cast, you can't see that. They're going to be complaining of leg pain maybe because it hurts. Sometimes these people will present as just extreme air hunger and then go into a respiratory cardiac arrest. Maintain the airway, support breathing, high flow, high concentrated oxygen, assist ventilation is needed, intubation is needed. If they go into an arrest or near arrest situation, treat them as an arrest situation. We have a couple of great cases where we act, especially one from Camas, I think we brought up a couple of years ago, that came that CPR was maintained to the hospital. Patient had recent surgery, minor surgery, collapsed, went into a full arrest. They had an ROSC, got to the hospital, and with that information, the patient went right to interventional radiology, and the clot was removed, and the patient left the hospital a few days later in good condition. That's a rare case, but it's good when you get one like that. And of course, transport to the appropriate facility. Either facility can do it, but if you think it's the definitive treatment is often now interventional radiology. That's a 24/7 thing at Peace Health. It's not 24/7 at Legacy. Pneumothorax, something is near and dear to my heart. Very close to my heart, actually. Except mine wasn't a spontaneous. It happened real quick, but it wasn't spontaneous. Spontaneous pneumothorax occurs in the absence of blunt or penetrating trauma. Risk factors include smoking, asthma, other underlying pulmonary disease, and it's somewhat hereditary as well. You get you have little blebs that are little blebs close to the pleura that simply rupture. There's often a preceding coughing or lifting episode. Historically, I have had a couple patients that were smokers, so they were at higher risk, and they said, "Oh, I lit up a match, and I got this sudden pain in my chest." And I think it's from the smell of the match, and you take a good inhalation, and it seemed unusual that at least two of the patients had that symptom. So they have risk factors. They'll have a sudden, sharp pleuritic chest or shoulder pain. They may have decreased or absent breath sounds on the affected side. They'll be tachypnic, usually a little diaphoretic pallor. Maintain the airway, support breathing, monitor for tension pneumothorax. Normally usually a spontaneous pneumothorax does not go on to be a tension pneumothorax. Now it can happen. I've certainly seen it, but you should be able to monitor that. Now, you could perhaps encourage a tension pneumothorax by using positive pressure ventilation at that point, because you've got a pleural space. Normally the lung is working under negative pressure. If you do positive pressure, you could force air out through the tear in the pleura and continue to collapse the lung and create a tension pneumothorax. I mean, the number one cause of tension pneumothorax in the country is actually iatrogenic. It means we caused it because we're doing positive pressure ventilation on people. So, and it's, of course, if they develop a tension pneumothorax, then you do a simple pleural decompression. Now, I don't want to see the same thing happen that happened to me. I don't want to see the two paramedics fighting over which one is going to do the pleural decompression. I knew both the guys, so I told them to hang on, to stand back. Stand away from that needle. Tracheal deviation and jugular venous distension occurs in tension pneumothorax. JVD occurs, but tracheal deviation is such a late sign, and it's best picked up by X-ray that I don't want you to hook on it. I want you to go on the symptoms of the patient. If the patient's not doing well with their O2, they're getting more tachypnic, they're getting more difficult to take a breath, they're becoming more agitated, just go ahead and needle the chest. Second intercostal space, mid-clavicular line. Hyperventilation syndrome, have to mention it's part of the rapid breathing, chest pain, numbness, other symptoms. Basically, it's caused by the patient becoming alkalotic. They're blowing off their CO2. They become, for whatever reason, they're breathing too rapidly, and they can be either rapid breathing or deep sighing respirations. Their CO2 decreases. They become more alkalotic, and that causes shifts in at the neuromuscular membrane, and it causes the symptoms of tingling, numbness, carpal pedal spasm. As soon as they get carpal pedal spasm, by the way, they know they're going to die. They get anxious anyway. They hyperventilate. And as soon as they get carpal pedal spasm, they say, "Oh my God, I'm going to die." They also get chest pain associated, unusual chest pain. They know they're going to die, and then they breathe faster, and then they get worse. So, however, many, we used to treat it by having you rebreathe. We don't do that anymore because there are many medical problems that can cause hyperventilation. So we're not going to we treat the hyperventilation by slowing down the respiration. What's the end point of hyperventilation, by the way? Yeah, the patient passes out, and that takes care of the problem. Nobody hyperventilates by themselves while they're resting like that. So acidosis can cause hyperventilation syndrome. Beta agonists, too much beta agonists. They've sucked on their inhaler too many times before you showed up. Asthma, cardiovascular disorders, congestive heart failure, fever, sepsis, hepatic failure. High altitude disease, etc. The pain can cause it, on and on and on. So, focus history, physical exam. They're probably complaining of fatigue, nervousness, dizziness, dyspnea, chest pain, numbness and tingling. They may have carpal pedal spasm, tachypnea, tachycardia. Maintain the airway, support breathing, high flow, high concentrated oxygen, assist ventilation as needed. Don't treat them with a rebreather. You make all those other things worse if you do. Reassure the patient. Can you sedate the patient if indicated? If they're so agitated, yes, go ahead. I mean, they may be on meth. They may need to be sedated with benzos. They may even need to be sedated with an Apsine. That's a judgment call. You can call medical control if you have a concern about it. But if you're there managing their airway, there's no reason not to sedate them. We'd like them not come in so sedated that we can't talk to them afterwards, but that's the only thing. I'm going to kick through that. That's I'm not going to mention that today. So that sort of covers my my respiratory thing. So I have to go into my usual Alps refresher. Okay. Well, Alps inclusion criteria. We've got a new thing to add to this too, but it's a very Alps inclusion criteria. Non-traumatic, out-of-hospital cardiac arrest with vascular access, either an IV or an IO, and persistent recurring VFib, VTAC after one or more shocks. By definition, then, that means after one or more, which means, by definition, you have to give in 2 shocks, because we're in no peaky state. No peaky. That means you can't look at it after that first shock and say, oh, by God, he went back into VFib. You only know that after you look the second time. So you've done a round of CPR, you shock the patient. You do another round of CPR, get your IV in, get all this stuff going, and you look. The next time you look, after 2 minutes, you look and it says, oh, VFib again. You shock the patient. That means you start using drugs after that point. Now, you might have used epinephrine in that first thing. I mean, you could have been really, really, really quick. I don't care. But you're not using a dysrhythmic drug until after you've seen VFib twice. Or someone else with an AED has shocked the patient. The AED means it was VFib or pulsus VTAC. Okay. So it means 2 shock, whether it came from the AED, whether it came from you. If you get there and the AED has popped them twice, you've got auto coverage to do your Alps right at that point. You're clear for takeoff. Now, no open label amiodarone lidocaine. No known hypersensitivity to amiodarone or lidocaine. How would they know? They're dead in front of you. They can't tell you. Protected populations, prisoners, minors, pregnant persons, trauma deaths, those are the no study braces. Has anybody seen a no study braces on this case, for a Alps case? I haven't seen one reported. So shock. Any shock administered by a ROC agency, us, a non-ROC EMS agency, Cowlitz, fire, a first responder, AED, a public access AED, a police AED. No ICD shocks, and we had one question this month. We had one of those life vests go off. That also doesn't count as a shock, because you can't prove it. And those things have been known. Isn't that nice? I put on my vest and it shocked me, and I wasn't really in VFib. Better than nothing, I guess. But those count like ICDs, so they don't count. But if any real machine gave a shock in your hands or in anybody else's hands, that counts as a shock. So persistent recurring VFib is VFib or VTAC anytime after the second shock. If you're thinking, hey, it's time for a dysrhythmic drug, then it's time to go to your Alps. That's only 17% of your codes. Study drugs need to be given as soon as possible. We want them in within 10 minutes or less after your arrival. So, and they can give it immediately after the epinephrine, as long as you flush it. Now, I'd rather, and the question is, should I give the Alps before the epinephrine? No. Try to give the epinephrine first. And we were trying to follow our standard protocol. If VFib, VTAC returns, you carry out the full Alps procedure. So your first Alps procedure for the adult of normal size is syringe 1A and syringe 1B. Then you do a round of CPR, you look back at your machine, and it says VFib still. You shock the patient, and you give syringe 2. Okay. Late recurring VFib, VTAC doesn't make any difference. If you're into the second shock, if you've been there, you shock the patient once, and you get return of spontaneous circulation, and you're just tooling on down to the hospital, and he goes back into VFib. You shock immediately, and then you can go your Alps. So, anytime you've given 2 shocks, even if there's a time period between, you're into Alps territory. Okay, the first dose is the 2 syringes, 1A and 1B. Second dose is syringe 2. I don't think, although we tell you to go for little itty bitty tiny people, to only go with syringe 1A for the first dose and then 1B for the second dose. I don't believe we've seen anybody that fit that criteria. I mean, you've got to be about this big to fit that criteria. What if you give all the study drug? And we have. What if you give all the study drug? You can use other antidysrhythmics such as magnesium. You can use more doses of epinephrine, but you can't use open label amiodarone or open label lidocaine. You can do as many shocks as you want to do. Now the magnesium now. What if you got a patient that you say, oh, this is pulseless, this is a pulseless patient who's in torsades? You say, by God, right away this is, I think this is, so you shock the patient and they stay in the torsades rhythm, and you shock them again, so you got your 2 shocks in. Can you give magnesium before you give the Alps drugs? And the answer is yes. That has occurred once in my review of all the cases we've done. By the way, we still have the most, we are at about, I think Clark County is now entered about 100, as I recall, about 160, give or take, cases. And you're doing very well lately, and actually overall it's doing very well. There's a few cases we missed. And the study itself is about halfway through now, so as it seems to be picking up, it was a good summer. Lots of people having cardiac arrest, I think. Yeah. Okay. You got to use that ClearLink adapter. We've done very well, but I just keep pushing. You have to use the ClearLink. Use the ClearLink. They had several cases of failure in Washington County and Clackamas County because they didn't either use the ClearLink or they broke the syringe when they're putting the ClearLink on. The Alps syringes are absolutely ridiculous, and they're not compatible with the lower lock. It's a glass thing. The acrylic pin inside the lower lock blocks the flow. So you have to put the ClearLink adapter on the IV tubing before you put the syringe on. You put the syringe on and turn carefully, no more than a half a turn. So far, I don't believe we've broken any of them attaching to the ClearLink. So everybody knows what the ClearLink looks like. If you enroll a patient, call the number. It's written down. You don't have to memorize it, because we have to notify all patients or their families that they were enrolled, and then they get a chance of opting out. But we still keep the information up to that point. We can analyze that, so that's good. The hospital emergency department should know the patient's enrolled in Alps. They don't know what to do with it beyond that point. They say Alps patient, because they don't have to do anything more. They may question you about whether you know what you gave them. And of course, you can't tell them that. There's no logic that I can figure out that anyone would really need to know that in the hospital at that point anyway. But we can break the code if absolutely necessary but it's a difficult process, and they don't get any information quickly enough, so it really doesn't help treat an emergency anyway. There's nothing, no big a deal. They just have to adjust their dose of amiodarone and or lidocaine if they're going to use either one, and they can do that by the information that comes from the little piece of paper you give them. Document what you would normally do in the case of cardiac arrest. If you use your monitor, write down on your chart. We used our monitor. If you used Vancouver, if your AMR and Vancouver Fire's monitor was used through the whole thing, put down Vancouver Fire monitor. And then you upload, whoever did the has to upload the CPR process file, the PCO file, and you guys know how to do that. Yeah.
Rock will call on it 2 or 3 times a week to try and get the file. You guys have problems if cables are broken, if the monitor doesn't work, if the Bluetooth doesn't connect, whatever, I mean, call right away so we can get it fixed.
Yeah. Ultimately, we'd like you to upload all PCO file. Not today. Ultimately, we want to see everything you're doing, whether it's on a cardiac arrest, whether it's on a patient with an MI. We'd like to see your PCO file on all those, and that's what our ultimate goal is, to get all those things coming through our office too, so we can see that stuff right at the bat. Yeah. The entire event.
Turn on the unit. As long as you click all. Click summary. Right. Yeah, you gotta click all.
Click all.
And it's, I mean, the point is by doing it, by having this program, it makes it easier for you guys to document the call. I mean, pushing buttons is a lot easier than PayPal.
Yeah. Yeah. Right, and then faking it. Yeah. Which is timestamp each dose. Timestamp each dose if you can. We know that you fudge that one, but because it's only as accurate as it can be. If we could stamp it, if you can put an event, click on your PCO file, then we can cross-check that. It needs the study drug kit number, barcode, swiped in, and that's that. So bottom right-hand corner. Close this file. Yep. Yeah, enjoy. It's got to be good. Okay. Couple of case reviews. 35-year-old witnesses, friends, stated he experienced a syncopal episode with seizure-like activity, described as sitting in a chair, complaining of feeling hot, not well. They gave him a cold towel to put on his head, which is, of course, an excellent treatment for most anything. And then his eyes rolled back, and he started a seizure-like activity with his arms, lasting only a few seconds. What's that sound like? What's that kind of seizure-like activity? You get a couple of tonic-clonic twitches often when people pass out, faint. It's sort of, whether it's hypoxic in nature or what. And then this happened at an additional time. Then the patient threw up. He's on arrival, seated in a chair, not feeling well, and he has a headache. Denies chest pain, shortness of breath, blood pressure is 110, palpable, heart rate's 84. 4 lead shows a sinus rhythm, put on a stretcher. Given 162 milligrams of aspirin, 12 leads performed shows septal anterior MI, possibly, with ST segment elevation in V2 and V3, and they specifically wrote down no mimickers. No mimickers. Okay. Well, here's our first guy. Now, okay. So, oh well, this is some interesting ST segment elevation, it appears, and this is up to and arguably there, but so we've got at least two things. And they liked it so well they repeated it, and indeed he's got the same kind of pattern. He doesn't have left bundle branch block. He doesn't have criteria that meets for hypertension, for left ventricular hypertrophy, which would be our most common mimickers. So, STEMI was activated, IV given nitro. At arrival at the hospital, the patient says he has a full feeling in his entire body, but also specifically states his neck and his arm, and he's delivered to the ED staff. Now, I think this was good care. This was an interesting thing, but if we go back to this one, this is actually a mimicker, and this is the one lead that really shows it off, which is, you know, your ST segment elevation normally goes up and then stays up. This you can see this little dippity do here. That's kind of okay. Goes yep, dippity do down. So it goes up, drops down, and then comes up again. This is kind of characteristic. It's nice when you can find that and you think about it. That's early repolarization. And you don't see it anyplace else that I can really see, which is kind of unusual, because usually you find a couple of other ones that'll show that off. But you can't fault anybody for that, and I don't. And they called us, and the ER doc didn't know for sure, and the cardiologist said, "Well, I think this is probably early repo," and so they got the record from the patient at Kaiser, and he had a 12 years ago at an EKG shows exactly the same thing. So that's the nice thing about having old records available. So, however, he needed to be worked up for his syncope, because that's kind of important, where you just pass out and you have all these things. And it was probably due to his alcohol and marijuana and little dehydration, so they sent him home the same night after all of his tests came out negative. But that's a STEMI activation that I don't mind seeing, because, you know, everybody thought this was really significant. And you couldn't, even the cardiologist was, let's see an old one if we can. It's always nice if you get those. Okay, a trauma patient. Motor vehicle accident, motorcycle wreck, moderate damage, a 30-year-old male patient walking down the street toward EMS with obvious broken arms. He's traveling approximately 30 miles per hour, lost control on gravel, and went over the handlebars. Doesn't think he lost consciousness, doesn't think he hit his head. Witnesses report that he probably lost consciousness briefly, then got up and began walking up the street, but appeared to be altered. Like not just broken arms, but altered mental status. Denies. Past medical history, no meds. Denies any drug or alcohol use today. Chest pain in right shoulder, both arms. Alert, GCS of 446. Some confusion and repetitive questionings. Also keeps forgetting he injured his arms. You know, he keeps going like this. Over here, you know. I don't know. Breathing is normal, unlabored. Helmet appears to be intact. No trauma noted. No trauma of the neck. No pain or deformity palpation. No trauma noted of the back. No pain or deformity. Chest has abrasion in upper right side of chest and clavicle. No deformity crepitus notice in chest wall. Lungs are clear. And abdomen is normal. Pelvis, no trauma noted. Extremities, swelling and deformity to right clavicle. Closed, unstable fracture to left forearm. Proximal wrist with swelling, deformity. Fracture, dislocation of right elbow with significant swelling. Possible right mid forearm closed fracture with swelling and deformity. No trauma noted in legs, and he was ambulatory at the scene. Heart rate 136, respirations 18, blood pressure 140, palpable, SpO2 95%. Stasis pain level is 2 of 10. Okay. Does this guy get entered into the trauma system? Trauma alert, trauma team? Okay, trauma alert. How do we package him and how do we transport him? C-collar. Sitting up. Why would you transport him sitting up? Doesn't count. Okay. Here's what they did. Splinted both arms, modified C-spine precaution with C-collar and gurney, semi-Fowler's unit, moved to medic unit, code 3 to PHSW, reassessed. And he was transported in semi-Fowler, semi-sitting up. Here, arrived in hospital, transferred care to ER, ED, RN, and MD staff. Okay. Did he pass the C-spine protocol? Nope. So he basically qualified right off the bat for full C-spine. Now, the argument comes down to immobilization on a backboard. He's been up and walking around. Is he otherwise impaired? He lost consciousness. He has altered mental status. He has several distracting injuries. We don't know, and he said, yeah, altered mental status, and he says he's not had any drugs or alcohol. So, he should be on a long backboard unless you say, well, there's some reason that I'm not going to do that. But at the very least, he needs to be in a C-collar, needs to be restrained to a gurney or secured to a gurney, and unless he has a difficulty breathing that is affected by that, he should be transported. Why in the world would you transport him not laying down? He should be transported laying down, flat. And that's how we want to see these guys come in when they're like this. Arguably, he could have gone on the left. He probably would have argued the point himself, but he didn't remember his arms were broken either. So he can't really hit you. You know. Okay, in the hospital is alcohol. My goodness, is 0.12. There's also a significant question that there's marijuana. We don't test for that. Right elbow fracture involving radius and ulnar, right wrist fracture, left wrist fracture dislocation, significant abrasion base of neck. CTA was negative. Closed reduction. So he had a closed reduction of left wrist and the right elbow because of the dislocations. You get those things fixed quickly, and then ultimately was discharged to Kaiser when he was put on full C-spine precaution prior to CT. Went over from in the department. The trauma surgeon got a little excited, of course, and all of his C-spine films and other CTs came out negative. He got a full bore CT workup, of course. So, and then he went to Kaiser for definitive surgical fixation of his fractures because he got a lot of them. He was a Kaiser patient, of course. Okay, case 3. Patient woke up at 3 o'clock in the morning feeling short of breath. Symptom progressed to the point where he called the staff. Staff found the patient on the bed, appearing very sweaty, struggling to breathe. Said he felt completely normal prior to going to sleep. No chest pain, nausea, vomiting. fever, cough, diarrhea, any other medical issue. He's on dialysis. He was scheduled for dialysis. Later in the day, you're there. He didn't miss his last appointment. Sitting in a chair, appeared to be in respiratory distress, effort in breathing. He had relief with the treatment. Still short of breath. Skin is ashen color, warm and clammy. Wheezing throughout. Pulse ox 85% on room air. EKG sinus tach. Oxygen 100 liters. He gets improved O2. Med-neb albuterol atrovent improves a little bit. Blood pressure is initially 231 over 125. Pulse 126. Respiration is labored. GCS is 15. Blood glucose 123. Gets a little IV going. Methylprednisolone given. Pulse ox now 100% and stayed at 100%. So he's gone from 85 to 100%. Got another med-neb albuterol. Wheezing in the upper lungs clear. Capnography 29. Capnography repeated 31. Respiratory rate 24. GCS 15. Thing missing. This would have been a good case to try him on CPAP. Respiratory distress, wheezes, you can give him his med-nebs through that. But he's also, with the dialysis and that hypertension, by the way, the hypertension improved with having his lung function improved, he's fluid overloaded. So he's got some pulmonary edema, some interstitial edema, and this will improve. Now, he didn't require intubation, but this is the kind of person that often goes on to intubation. CPAP could relieve that. He was put on BiPAP, hospital version of CPAP, on arrival and improved. He was admitted for 2 days total. Fluid is offloaded. He was dialyzed. Dialysis patients frequently get fluid overloaded even if they're going through the dialysis. And he had COPD exacerbation, and he was discharged home. Now, whether the COPD was exacerbated by his fluid overload, which gave him interstitial edema, which then gave him more problem with the COPD, that's probably the way it goes. Now, this last one is a very, before I do that, I don't want to miss my train of thought here. Dr. Mock had to work a shift today, otherwise he would have been here, but he had to work because he's standing in for one of his other associates who couldn't work today. We've been going through we've had some cardiac arrest questions that have come up over the last couple of weeks relating to CO2. So, and relating to where we will take the patient. So the first question, and we can answer this, I'll throw this out for the group. Got a patient in cardiac arrest in asystole. You've done 2 to 3 to 4 rounds of ACLS medications for asystole. You still have asystole. The patient has a CO2 of 24. Do you transport that patient or do you call it? Okay. The question relates, the patient said, well, we have a high CO2. How can we call it? No, that's not the question. You can always call it if your CO2 falls to 9 or below. That is guaranteed evidence that that patient is deceased. A lot of times, though, we'll work in asystole or something, and you've got a patient who started out maybe at 50 on their CO2, and they get down to 24 and they've had no result, no nothing. I mean, your test is, are you getting anything that you can otherwise treat? So there's no reason to transport that patient based on the CO2. Now, conversely, if you have a patient who's at 20, who starts at 20 in CO2 and then bumps up to 36, he may have had a return of spontaneous circulation at that point. That's the test we're looking for. But you can call it based on your clinical impression of multiple failures of your treatment at that point. There's nothing more we can offer the patient at that point. You guys do the best CPR in the county. You know, if they're not responding to your CPR, they're not going to do it by magically taking them to the hospital. That's not going to help. So the next question is, where do you take a patient who has had an arrest, but you're absolutely convinced that the patient had the arrest because they were severe asthmatic and they were in the middle of status asthmaticus and they went to an arrest? If you get a return of spontaneous circulation, where do you take that patient? Well, good for you. I would say you could actually take that patient to the closest hospital, because that patient is not going to go to the cath lab. So you can take that patient. You know, that's not a cardiac arrest. That's not an arrest from a coronary artery spasm. That's not an arrest from something. You know, but you know, you could take that patient to any. Now, ordinarily, we like any return of spontaneity for a cardiac cause. We would want that patient to go to Southwest, because the odds are that that patient is going to go to a cath lab either immediately or, actually, it was a good case we had just the other day, cardiac arrest, ultimately return of spontaneous circulation. Patient hasn't woken up yet, but went immediately to the cath lab. There was a delay of, there's a stabilization in the ED and then into the department in less than 10 minutes, and the patient had a balloon up within 30 minutes of arrival at the ED and left the hospital happy in about 2 days. So that was another Camus case, as I recall, too, but we don't want to say that they're good at that. So, okay, last case. Short of breath, patient sitting in a chair in the living room, moderate shortness of breath and fire taking vitals, 73-year-old, shortness of breath, past history of pneumonia, diagnosed 5 days ago, past history of splenectomy in 1962. Is that important? Is that important? Yes, it is. We don't like splenectomies on people. We don't do splenectomies on children with spleen injuries anymore, unless they're so fractured they're just bleeding out. We try to save the spleen because the spleen protects you against a number of things, including pneumococcus. So anybody who has had splenectomy needs to have their pneumonia vaccinations, and you need to be very cautious when they have pneumonias. Well, this person did have pneumonia. 5 days before he was reasonably okay. He'd been seen as an outpatient. They started him on cefpodoxime for his pneumonia, which is sort of gorillacillin. It's a big killer. It should cover most. Well, it'll cover some pneumococcus. Problem with strep pneumonia is that it's resistant. Some of it's resistant now, about 40% resistance to penicillins and the cephalosporins. He's been more short of breath for the past 2 days. They should have warned him more about going in. He's awake, alert, oriented, skin is moist, lungs rhonchi in the left upper and lower. Blood pressure is 188/90, heart rate's 103, O2 sats are 85, blood glucose 148. had some wheezes, started with the Med-Neb, responded well to O2 and treatment. En route, he has AFib. Monitor shows AFib with a rapid ventricular rate between 136 and 176. Started feeling more short breath again. Medical control consulted and suggested that they would agree to diltiazem for his AFib to slow the rate down. It worked, did slow his rate down, didn't improve him much. Now, this is another case. O2 sats are 85. Blood pressure was up. Why not BiPAP or CPAP? CPAP and his Med-Neb. So he put on BiPAP in the ED, increasing respiratory failure. Respiratory rate's 40. His PO2 with BiPAP is 50. Continues to decrease. Eventually he's intubated. His blood gas pH is 7.17. PCO2 is 41, so he's quite acidotic. Probably lactic acidosis at this point. This is a clear case of sepsis. PO2, after intubation, his PO2 gets all the way up to 61. He has near total opacification of his left lung and consolidation of the right mid-lung field, so he's got bilateral pneumonia. He developed acute renal failure, ARDS, goes on to multi-organ failure. Continued AFib with rapid ventricular response despite treatment, treated with multiple antibiotics. Ultimately, was transferred to Emmanuel to put on ECMO, extracorporeal treatment to get some oxygen in his blood, because it's not coming through his lungs anymore. He is still at Emmanuel on ECMO. And they're not 100% sure, but they weren't at the time we wrote this up, whether this was a common or atypical pneumonia, where it was common pneumococcus with a variant, or if it was just an atypical pneumonia. Now, he had a recent travel to the Middle East. He brought his camel back with him. Just the urine. Yeah. So, but another case where, well, not that we would have made any. This is a very unfortunate. You feel bad I feel bad whenever I'm reviewing a hospital record and I look at the admitting internist, or I look at the report from the ER physician. I look at the specialist who's been the pulmonary specialist, and they start out, "This unfortunate gentleman." Damn, I hate that. So, okay, end. Any questions? Yes?
So if we're right on being in a public access defibrillator that's being used,
Yep.
should we bring that with us? Are you guys going to download it later?
It doesn't make any difference. The public access, ultimately we'll try to query that. We're going to go into it. We're going to be going into a new research project that you won't have to worry about, which is going to be to identify all the machines in Clark County. And right now, the only time you'll get a download, we'll get a download if it's a public access thing that's in a high school or one of those things. The ones downtown, not all of them can be interrogated. We make the assumption that any AED, any fully fledged AED, will not shock a non-VFib rhythm. So that's why. Now we know that AICDs do funny things. We know that apparently the life vest also does funny things, apparently. So, but any real AED counts as a shock.
So don't worry about bringing it with us.
No.
Like
No, don't carry it. It needs to be on the wall. We'll see ultimately if we can interrogate it if it's important.
They may need it. The new abridged protocols, for those of you who carry the little thing in your pocket, are available. For the other ones of you, technologically a little more advanced, if you want it in PDF format, I can send it to you. You can save it to iBooks, and it pops up on your phone.
iBooks, yep.
You know what that is?
You know what book is?
Yes, they will be available.